Hello everyone, I'm Dr. Diksha Pandey and you are watching Urogynecology for Beginners. Today, Dr. Subriti, who is a fellow in urogynecology here at KMC Manipal, is going to present an interesting case. We have not discussed this kind of case before in our, so every time we bring you a new
Something
kind
new.
of case.
Yeah.
Okay, so she will be presenting history and examination. Meanwhile, I'll keep on interrupting her, asking her questions. We'll keep on discussing so that you can understand the case easily and effectively. So can we start, Subriti?
Yes, ma'am. Yes, ma'am. So, I would like to present the case of Mrs. X. She's 37 years old. She had come to us with the main complaints of backache and mass per vaginum since the past 6 years. So, ma'am, elaborating on the mass. It is not jutting out of her vagina, but she feels a certain heaviness in the vagina which has increased over the past 6 years. And she feels that towards the end of the day or after she's done with heavy work or any kind of work, that increases, which we know is the signature symptom. Other than that, ma'am,
Signature symptom of pelvic floor defect.
yes, ma'am, defect. And she has no urinary complaints, no bowel related complaints at present. But main problems were these only, ma'am: backache and heaviness of the vagina. More on her history. She has no medical or surgical comorbidities. The most important part of her history, ma'am, is her obstetric history. So, should I start with that?
Yes. So let me just summarize.
Yes,
she is a young patient,
Yes, ma'am.
only 37
years old. Yes.
lady who has presented with some mass per vagina which is troubling her.
Yeah.
And we have found out from the history that it looks like some kind of pelvic floor defect.
Yeah.
As Subriti very beautifully said, with the signature symptom of pelvic floor defect, that is that the symptoms, any kind of vaginal heaviness, vaginal mass, those symptoms should increase with the passage of the day, with
Yes,
increased work.
With work and
Yeah,
it gets aggravated.
which actually represents increase in intra-abdominal pressure.
Yes, ma'am. Yes, ma'am.
And which disappears with rest.
Yeah.
So that kind of problem patient has presented with, and Subriti is saying that her obstetric history is the most interesting or significant one.
Yes,
so let's hear.
So she had her first pregnancy 10 years back, and through the 9 months, it was an uneventful pregnancy, is what she tells me. However, the size of the baby was very big, ma'am. She gave birth to a 4.5 kg baby, but there was no diagnosed diabetes or anything during the course of her pregnancy. She went into spontaneous labor, and it was an institutional delivery. She says that she was admitted for about 4 days when she was in labor, and that whole process went on for 3 days. She was also induced with prostaglandins. She gives history that she was given tablets through the mouth, through the vagina, everything. She does not remember that at the time of delivery, like she tells that obviously this labor process was prolonged, but even her delivery was very difficult. She doesn't give any history of instrumentation, she doesn't remember, but she says this very clearly, that they gave her a very large cut. So after that, when she delivered, it was a difficult delivery, and post-delivery, while the epi was being sutured, she says that it was a very prolonged process, around 1.5 2 hours. And after this, after all of this was done, actually, ma'am, the baby had asphyxia or whatever. The baby succumbed within 2 hours of birth. So this is what happened in her first pregnancy. And post this first pregnancy did not end. Right after, like maybe the next day or something, she had fever and constipation for about 2 weeks. She had very severe fever, some kind of infection, because she said she was admitted for 2 weeks and she was given injections, I believe IV antibiotics. Post that, she went home. She did not resume her whatever household work right away. She tells this very clearly, that for 2 months, because she was very disturbed and everything, she rested completely. And after that, she resumed her household work. She didn't have any complaints of any urinary or bowel related complaints post this event. Then she had her second pregnancy. Now this pregnancy happened 2 years after the first one. In this pregnancy, ma'am, from fourth month onwards, she developed this heaviness in the vagina, and she said that towards the end of it, like at the end of when she reached term, there was a mass outside of her vagina.
Okay.
Yeah. And again, ma'am, she went to the hospital, like she went into spontaneous labor. This time her baby was around 3.6 kgs. She went to the hospital. After she reached the hospital, she again underwent a normal delivery only. So this time it was about 12 hours. Like she got admitted in the morning, by evening she had a baby in hand. And she doesn't remember anything about instrumentation, no nothing. Doesn't remember the epi being as painful, but it was definitely given. And this mass that she said had come out during the course of her pregnancy, she said that those symptoms resolved and she couldn't really see that mass after. But she felt a heaviness in the vagina, which sort of increased over these 6 years. But she doesn't have any other complaints, except for the past 6 months now, she's complaining of backache and this heaviness having aggravated to the point where it bothers her a lot.
So many points you told.
Yes,
So
ma'am.
I'll take it one by one.
Yes, ma'am. Yes, ma'am.
So one thing I always say that what is preventive urogynecology? If you want to prevent urogynecological things, you have to practice good delivery.
Yeah.
Okay. So the dictum which we use often is that good obstetrics is preventive
Is preventive
urogynecology.
urogynecology. Yes.
Okay. So here so many things have gone wrong. And this is one message for even those people. I think some of the people who are non-OBG people also, or non-doctors also are watching our this YouTube videos.
Yes.
It is an important message for them also who form the patient population or are relatives of patients or are doctors.
Yes.
Okay. That this is in our head that vaginal delivery is
the
the
best.
way, is
Yeah.
the best.
Yeah.
I'm not saying that it is bad or cesarean section. I am not endorsing cesarean
ma'am.
sections. But I think when we have another option, we should always think about it. And in indicated cases,
Yes, yes, ma'am.
we have to always weigh the risk and benefit. Even cesarean delivery is a very, very good option. Okay.
Yeah.
I'm not saying that every patient should undergo cesarean, but in cases where it is required,
It should be
cesarean
done.
Should
be done. Yes, ma'am.
We only have incidences where patient
Yeah.
has fought
Yeah.
that we don't want cesarean. Okay, somehow we want to deliver vaginally.
Yeah.
And we have explained to it, some have understood, some have
Some
not.
have not. Yeah.
Okay. Sometimes even in doctor's mind, it becomes like an ego. When you induce labor and when you start giving, when you tell patient that I can deliver you normally, then
Yeah.
it becomes sometimes we want to deliver that patient
Yes, ma'am.
with ease or without ease, with forceps or something, that becomes our ego that I'm the doctor who delivers patient vaginally. That should not be our aim.
Yeah.
At the end of any labor or any childbirth, our aim should be to
Healthy mother, healthy baby.
see. So this is again, she did not think it. She said first thing is healthy mother.
Yeah.
Okay. Yes, we want a good baby, that is okay. But sometimes even if when this patient came to me first time, I thought that first time 4.5 kg
Baby
baby,
survived.
they delivered vaginally because it was a dead baby. That's what.
Oh, no, ma'am. No.
So later I came to know about the story. First time when I heard in Hari in OPD,
Yeah.
I thought that they gave vaginal birth to 4.5 kilo babies
Because it was an
because
IUD.
it was a dead baby.
Okay.
But even in that case, we have to remember that okay, baby, you cannot do anything,
Yeah.
but at least pelvic floor of mother
Of the
is
mother.
still important.
Yes, ma'am. Her
You
quality
cannot-
of life.
Her quality of
Yeah.
life is still important. So it's not that every time we are doing cesarean for the baby's sake. Many a times we have to do cesarean for the mother's sake. And it is not only to prevent preeclampsia or to treat preeclampsia or some medical disorders. We have to keep in mind the pelvic floor of mother also, because that is important as quality of life of patients.
Yeah, absolutely.
Very, very important. So this lady was in labor, prolonged labor,
Yes, ma'am.
which is totally unacceptable. I don't
For about
know.
3 days.
That
yeah.
is her
That
experience.
is her, exactly. Everything
Her
what we are
experience,
saying is
but-
what she's told
But
us.
even I think this is such a beautiful journey a patient goes through of pregnancy and childbirth that should not remain in her mind as a
As
misery,
a traumatic
as
thing.
a traumatic
Yeah.
event. She also should feel should be explained and she should understand
Yeah.
that it was a beautiful part of her life. She should remember it with
Fondly,
happiness.
or- yeah.
Fondly every time. Okay, so she herself is so agonized that
Yes,
she
yes.
tells that 4 days she was in labor. And on top of that, I'm sure that clinically or ultrasonographically, fetal weight these days it is not difficult to estimate.
Yes, ma'am.
Even if you don't have ultrasound machine with you, clinically you can have an
Yes,
idea.
ma'am.
how
And a
big is the
4.5
baby.
kg baby
Is
would
a
have looked
big
huge.
baby,
Yeah.
Yes, and patient is very thin
Very
patient.
thin. Yeah, so it would have stood out. Yeah.
Yes, and on top of that, inducing patient or augmenting
Mhm.
labor when it is showing some signs of borderline CPT, which is not correct.
Yes.
And then trauma to the perineum and to pelvic floor, what has happened to this patient. We'll discuss that in examination and in surgical procedure. So the ultimately goal, we are not fighting for that vaginal delivery versus cesarean
Not
section.
sure. Yeah.
Okay. We want to give our patient the best experience, not just for the baby's sake. We don't, as Dr. Jennifer says always, that mothers are not just baby incubators. We have our life of our own. Every mother has to have a quality of life. Our job is not just to give birth to
the baby.
So, okay. So we have to look into both aspects. And the more we think about urogynecological issues when we are delivering babies in our labor theatres, I think more will be prevented in urogynecology.
Yes.
This is one important message which I wanted to give from this case to all the practicing obstetricians.
Yes, ma'am.
Even we did not give a good quality to baby. Baby also succumbed, you said, within 2 hours.
Within 2 hours.
So for what we gave, what all, for whom we did all this.
Yes. Both of them had bad consequences.
Yes. So now let's see what is her examination findings. And so tell me.
So her vitals were stable. The general systemic examination was normal. Per abdomen, ma'am, it was normal. There were no findings. Soft, non-tender, no mass palpable. When we did the local examination, ma'am, there was no mass seen coming out of the vagina. And cough impulse caused gaping of the introitus. After that, when we performed a per speculum examination, the anterior compartment was fine, but there was a grade 2 rectocele that was present. And other than that, ma'am, in the rectocele, like the vaginal mucosa that we saw, above that there was a rent noted. That rent was about 2 centimeters in size. And when we performed a PR examination, the rectovaginal septum overall only was very thin and lax, like the whole appearance. But in this region where this rent was, it was really thin, like almost negligible. And right above this rent, on the left side, there was also a cyst. Like it was an inclusion cyst or retention cyst, we couldn't really tell, but a cyst like thing which was also non-tender, and there was nothing noted on top of it. And when we performed another thing in the PR examination, the rectal tone was very minimal, and her anal sphincter was very lax. Overall, her perineum was also very lax. And thin perineum, yes, ma'am. Very thinned out, like, yeah.
So these were her examination findings. So it is all the result of traumatic childbirth. Now, what we anticipate, what do you think, Subriti?
Yes, ma'am.
That during first delivery, most probably, I hope you remember that I keep on telling this thing, that first delivery, even if a lady comes to you with 11 deliveries, how her first delivery was conducted, that's the most important as far as the urogynecological outcome or consequences are concerned.
Yes.
Okay. And this was first delivery only
was a disaster.
Yes.
Yes.
Okay. So do you now the perineum is thinned out?
Yes.
You said anal sphincter tone is not
Tone
there.
was not
Anal
there.
sphincter is lax. Though she did not give any history of, she tells constipation, but she doesn't give a history of
fecal
flatus or
incontinence.
That can be explainable with one point, that when the motion is normal in consistency, okay, when the bowel movement activity is good or normal, then patient will have fecal incontinence. And when already there is a rectocele, everything is impacted. So it is not reaching the lower part until and unless patient is trying on her own. Okay? So it is a paradoxical thing which has happened, though the sphincter is lax, but patient has not
come with any
incontinence.
fecal or flatus incontinence.
Because what is holding it? The rectocele, pouch of rectocele.
Yes.
If this patient would not have had this rectocele compartment,
then probably
patient would have
full-blown
presented with incontinence. Okay, so that paradoxically prevented.
Yes, ma'am.
Okay. Now, if we are conducting a delivery, let's start with a clean slate. Suppose if by any chance you are attending, somebody calls you, your juniors call you, or some other obstetrician calls you that they are conducting a delivery of 4.5 kilo babies, and the baby is coming out, and you are there. As soon as the delivery is over, what are the things you will look for?
Ma'am, as soon as the delivery is over, firstly, we will examine the mother, her vitals, and then we go on to the local
Perineum. Yeah,
her
perineum. What are the things you have to? Actually, this practice should be done with every delivery.
Yes, ma'am.
Not with just one delivery or difficult delivery. We have to teach our postgraduates to make it a habit to check in every patient.
Yes,
so, what
ma'am.
are the requirements? What you have to rule out in every patient?
Yes, ma'am. So we have to rule out any kind of perineal tears, anal sphincter injuries.
Yes.
So when we are examining, we are going to see how the epi was given, if there are any tears like perineal tears, vaginal tears, cervical tears.
So we have to, perineal tear is something you have to see the extent of your episiotomy, because sometimes episiotomy only can be very
so deep. Yes, ma'am.
And sometimes episiotomy can be, that's more I am seeing in practice, that episiotomy is not properly angulated.
Yes,
it is
yes,
very close to anal sphincter.
Yeah.
And it is very important that every case, when you are seeing, you inspect, you palpate her perineum for all these tears. There are various degree of tears.
Yes, ma'am.
And very, very important, always do a rectal examination.
Yes, yes, ma'am.
To look for anal sphincter and inguinal mucosa.
Yes.
Two, so that we can prevent what we call as OASIS. And what is the full form of OASIS?
Anal sphincter injuries.
Yeah. Obstetric anal sphincter injuries. During delivery, what is caused? They are the most common cause of fecal inflatus incontinence in women in older age group, whatever they have sustained during childbirth. Okay, very, very important cause and easily missed. And lot of work is being done these days. Dr. Abdul Sultan and Dr. Rani are the pioneers who have given a lot of insight from UK in this subject. And it is very important. We are realizing that it is very important to check these. If it is missed, tissues will heal. It's not that everything will remain open. Overlaying tissues will heal with gaped wound or whatever way they have to heal, but the sphincter will not heal on its own.
Yes.
Okay. So, can you tell what is the approximate incidence of OASIS?
Okay, ma'am. So it is actually really, really common. It is a broad incidence between 16 to 61% globally.
16 to 61%. Easy to remember.
Yeah. But on an average, around 40%. And out of these, because only 10% are actually noted and given the kind of clinical attention that they should be given. Yes, ma'am.
So, very important. So, if you are conducting 10 deliveries in a day, that means 4 might be having some kind of...
and we would have only seen one.
Yeah. So, this makes it more simple.
Yeah.
So, very, very important too. And what is the use once it has happened so?
Yeah.
And now we see it.
Yes.
Can we do something?
We can, ma'am. We can repair it.
Yes. And immediate repair is the best.
Is the best. Yes, it is the best.
Otherwise, patient will, the way it heals, if you immediately recognize it and repair it then and there.
Yeah, there is a 12-hour window, ma'am. That is the best. Within 12 hours is the best.
So this was supposed to be my next question.
Yeah.
Suppose a person is
ma'am.
conducting a delivery.
Yeah.
And she or he recognize that the sphincter has gone. Okay. They have recognized it by per rectal examination. There is no tone. There is a defect, or even rectum has gone 4 degree perineal tear, and they don't know how to repair it.
Okay.
Say 3C or 4, whatever it is, 3B.
Yeah.
Sphincter has gone, or even whatever mucosa rectal mucus has gone.
Yeah.
And the person, it is 1 o'clock in the middle of the night, the person has come to, this is some junior person who is doing the delivery, and he recognizes or she recognizes that this has happened. What is your advice for them?
Ma'am, after they have checked it, my advice is that they should call the senior person on call. And
senior person who will come at 1 o'clock to repair your tear.
You will.
That kind of trust I want you to have. Okay. But suppose, what I want to emphasize that 1 o'clock, even if somebody, when I was an postgraduate student, we were taught that you suture something.
No, we shouldn't.
You shouldn't.
Do the correct closure.
Yes. We have to identify all the layers, specifically the sphincter.
Yes.
Take it out because it would have retracted inside.
The way it is done is different.
Yes. So there is no harm up to 12 hours, and 8
Yeah.
to 12 hours you can wait.
Yes,
You just
yes.
that way. These perineal tear won't bleed too much.
Yes, they won't.
Just secure some hemostasis, keep the patient NPO, keep the patient ready. Always call a senior person who has some expertise in repairing the tears. Take the patient to OT,
Yes.
give anesthesia under
And
good
then-
repair, good
yeah.
lighting, you must repair and
Yes.
assistance. Okay?
Yes.
So when we were postgraduates, what our seniors taught us that if it is repaired, you have to repair, but they did not tell.
How?
This was mass closure. Take out whatever they are doing, and we had seen them doing this.
Yes.
That is not,
Not the
going-
correct way.
Not the correct way, and that is of no use. Maybe little approximation will be there, but it is not going to prevent the patient from long-term consequences
Yes.
like fecal or fetus
Incontinence, yeah.
or compartment defects like
Yes.
rectocele
Yes,
and
ma'am.
perineal.
And lax perineal,
Lax
loss
perineal.
of tone, so many things.
Yes. So it is not going to. So if you don't know, it's
Hmm.
okay. You call somebody.
And you
You
have
can
that
do it.
12-hour window.
Yes.
Yeah.
And take her to OT. Don't start doing it when the patient is shouting, she's in pain, you don't have good light.
Yeah.
And don't start doing it. Just wait and do it.
Yes, ma'am.
Suppose now,
Yeah.
can you tell Subriti,
Huh.
what are the principles if you have to repair it then and there? Just
Okay.
a complete perineal tear. Many people keep on telling us to post a video of complete perineal tear repair. But in a way, I'm happy also that we are not
We are
getting
not
so
seeing-
many hard.
Yeah.
Maybe the obstetric care and labor room care is really good, and it makes me feel happy to say that we don't have any case. But even if sometimes, even if you have to do later, for this patient we did a repair.
Much
So,
later,
how
6
much
years
later?
later.
6 years
We
later.
don't know, maybe 10 years later.
Yes.
Yeah.
And the principle is more or less the same.
Yes, ma'am.
So you are going to tell me the steps,
Yeah.
and then if any input is required from my side.
Yes,
I'll give
ma'am.
it.
So, ma'am, the most important thing is, like we said, post-delivery, we should assess whether it is present or not. Second thing is, we should know which degree it is. That what are we dealing with? Whether it is an external sphincter injury. If it is external sphincter, then what is the extent of that injury? And whether it's an internal sphincter injury. Now, ma'am, coming to external sphincter injury, it is, you have to involve the fascia also in the closure.
So before that, would you like to tell about the degrees of perineal
Oh
tear?
yes, ma'am. So first, the grade 1, that involves only the skin. Second one involves the muscle. And then grade 3, A, B and C are there. In which A is when it involves less than 50% of the external sphincter. 50 or more is in grade B. And when the internal sphincter is also involved, that's 3C.
Very good. And 4th degree perineal tear means?
Complete.
Complete means even the rectal mucosa.
Yeah,
has a
rectal.
vent.
Correct. Even the rectal mucosa goes off. Yes, ma'am.
Now, just one concept which is very important, and you will understand it nicely. There are two sphincters for anal
Yes.
canal.
Yes, ma'am.
One is the internal and one is the external.
External sphincter.
So I always like to teach us external sphincter is like a rubber band.
Okay.
Okay, rubber band at the lower bottom part of the
Yes.
intestine. That rubber band which is holding it is
Together.
the external anal sphincter. What is internal anal sphincter? This is the muscle fibers which are traveling throughout the intestine.
Yeah, it's like a
They
barrel.
come and like
Yeah.
a barrel. They come and condense there and give some strength.
Yes.
So more important if you see is the external sphincter,
Yes.
which actually controls the,
The sphincter mechanism.
sphincter mechanism. Okay, and it is very easy. So if you understand it like a rubber band at the end of the anus, it is very easy for you to understand that if it gets cut,
Yeah.
even at one tear is there, it retracts.
Yeah.
Okay, like a rubber band.
Yeah.
If it is like a bangle, it will stay there. Two
Right.
edges. But because it is like a rubber band quality,
It is
going to retract.
Okay.
Then just holding the tissue and suturing it is not going to
Not
help.
enough.
You actually have to retrieve it from the inside,
Yeah.
pull it out.
Pull it
You
out.
can pull it because it
Yeah.
is a rubber band.
Yeah.
And then approximate it together. Okay.
Yes, ma'am.
It becomes more difficult. It is easier when it is fresh because
Yeah.
fibrosis has not set in. Only thing that you have to dig inside and search it out.
Yeah.
In later cases, when we did in
We are
this
dealing
case,
with
we
retraction
had
and
fibrosis.
fibrosis.
So you just have to do a little more dissection,
Hmm.
but still you can identify.
Catch
It
hold
is
of
not
it.
difficult to identify that rubber band
Yes,
and
yes.
bring it together.
Hmm.
And when you are bringing it together,
Yes,
then
ma'am.
we are talking about the sphincter. Let's talk about external
External
sphincter.
sphincter. Yes,
There
ma'am.
are two techniques to do it.
Yes,
What
ma'am.
are those two
Ma'am,
techniques?
one is the overlap technique, one is end-to-end.
Which one is better?
So, We did end to end.
Yes. So studies have proved that both have similar results.
Yeah.
Overlap means you hold this and overlap it.
Yes.
In this case, so
Yeah.
yesterday's case which we did,
Yes,
it was more difficult. In all cases, you cannot bring them too much overlap.
Together. Yes, ma'am.
Because we
And we
don't
struggled
want
with
and
that.
we don't want it to overlap because it is already fibrosed,
Yeah.
tissue is already retracted for a long time,
Mm.
and we don't want to cause fecal retention also
Correct.
inside.
Yes,
okay?
yes.
So the aim was never, it was not that we had difficulty, surgical
Yeah.
technique was difficult to bring it. We did not want to do it.
Yes, ma'am.
So, and if you see literature also and
It has
studies
similar-
also, it has
Similar
effect.
results. Okay.
It's your choice. What do you feel like?
Yeah.
If you get a lot good segment and if you're comfortable with overlap, you can do
You
it.
can do that.
If you don't want, you can do
You can do it
end.
end to end.
Then there is 3A kind of sphincter tear.
Okay,
Then
ma'am.
half of the initially people thought that this overlap technique is much better. It looks like, it sounds like. So 3A tear, they made it 3B.
Okay.
Incomplete tear, people have tried to make complete tear because incomplete tear you cannot do overlap
Bring together.
because they thought that they were so convinced that overlap technique is better. That
Sounds
if
stronger.
it was half cut, they
Yeah.
made it full cut, but it is not to be done. If
Okay.
it is a 3A, just
Go
side
for
to
end
side,
to end.
end to end, anastomosis is more than enough.
Okay.
If it is
Yeah.
complete perineal tear, we
Yeah.
are talking about that. We first layer is we have to do layers separately.
Yeah.
Okay, we cannot do mass closure.
Yes,
That's the
ma'am.
way I am telling you.
Yes, ma'am.
So first you have to identify the mucosa, the thinnest possible suture. You have to put it, suture it, repair that mucosa.
Okay.
Then you have to take internal anal sphincter.
Yes, ma'am.
Internal anal sphincter, you have to suture it together. That is like a sheath
Yeah.
from up to down.
Is it continuous, ma'am?
Yes, continuous also you can do and
Okay.
interrupted also you can
Whatever.
do. Doesn't matter.
Okay. Okay.
Whatever you are comfortable with.
Okay.
Important thing is approximating
The
the
external
external anal
Yes.
sphincter. So external anal sphincter usually we do with some vicryl and we do with two techniques and both requires interrupted sutures.
Okay.
That is the most important point because that's what gives us its real
Strength.
tone and
Yes.
strength. After that you can close the muscle and mucosa.
Okay.
So quickly, just can you tell what all we did for this patient? And
Okay.
we can, I think we have talked a lot about these kind
Yes.
of tears. And I don't want this to happen, but if suppose we get a patient of complete perineal tear which is fresh sometimes, this video also will try to upload it.
Yes.
But Subrati will just tell
Yeah.
what important points
We did in this case. So, ma'am, in this case, firstly, we held the posterior vaginal wall, we localized the rectocele, then we made a vertical incision and we separated out the Renon-Villiers fascia. After that, we have approximated that and repaired the rectocele. In the meanwhile, there are two things that I mentioned during examination as well. On the left, we saw something like a cyst. So while we were doing it, there was a small, like it got ruptured, whatever. So and there was mucin-like substance that came out. We excised that cyst.
So what
wall.
was the cyst finally? It was an inclusion cyst.
Inclusion cyst.
So
yeah.
if something which has glandular structure,
Yeah.
while suturing, if you bury it inside, if you have not taken too much care during
Yeah.
your repair, initial repair, maybe
Yeah.
that time,
That got
part got
accumulated.
inside and it started producing mucinous material
Yeah.
there. But it is important because if it gets infected, it
Yeah.
is a source of infection,
Infection,
and it can
yeah.
cause,
And even the
pain.
healing will be compromised.
Yes.
Another thing that ma'am did during this time, when we performed the per-rectal examination, we were seeing this thing on top. Ma'am, you suspected that it could be a fecalith or something like that. But we saw the consistency of it. We saw it was soft. And from the rectum also, we could tell that there is no impact with
So,
stool.
so how do you make a diagnosis of fecalith? Tell me today. In
Okay.
OPD also you might have this thing that you are doing vaginal examination, you feel a mass is there. Sometimes
Yeah.
first year PGs have this doubt
Yeah.
and there is something, they will say that some tumor is there in posterior
Yeah.
vaginal wall. So how do you differentiate any other vaginal mass from fecalith?
By doing a PR, ma'am.
No, if you don't want to do a PR. By vaginal examination, for every patient we don't do PR.
Okay.
And if you are anticipating fecalith, you don't want to do a PR.
Yeah.
Okay.
So
Okay.
through a vaginal examination, how to differentiate? How it will be a
So if you indent,
Okay.
if there is an indentation, that is a fecalith.
Okay. Okay. ma'am.
If you can make a mark, you can imagine it like a
Yes.
soap. If you can indent it, it is
Okay.
fecalith.
Okay.
If you are trying to indent it, but
And
you
it's
cannot make a mark
then-
or you cannot indent,
Then
that
that's a
means
mass. Okay. 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 I'll keep that in mind. Then there was a small, there was like a rent in the perineum that we had noted also. But when we incised, ma'am, we took care of that. When we were suturing
So
again,
redundant portion of vagina we removed.
so that was taken care of. Then after that, another thing was we also discussed that her anal tone was really compromised. So what we did was, after we had repaired this, say around 2 centimeters above the anal sphincter, we made a transverse incision. Curvilinear, sorry, I kept calling it transverse even then. Okay. So we made a curvilinear incision and then we dissected, and like ma'am said, we scooped out the sphincter ends. And after that, we performed our end-to-end closure, which has the same efficacy.
You have to dig it and take it out, dissect it, take it out, bring them together,
and then perform the end-to-end. Yes, perform the end-to-end closure. And after that, we close this incision as well. So what we did was that this entire area became a little taut, and we also noted that the anal sphincter tone, which was looking really lax earlier, started to look like there was some kind of stone available. We also checked, and
actually, patient was under spinal anesthesia, so obviously you cannot tell her to contract her sphincter. But look-wise also there was
it really changed.
That what do you call that, sun raying from the anus became more prominent after we did the sphincter closure. Okay, so that's it. That's what we did in this case. And before we forget, Subriti, do you want to invite them
Yes,
for something?
Of course I do. So on January 21st and 22nd, 2023, the conference is going to be just as fun as the date sounds. We have a conference. The acronym is URVASHI, which stands for Urinary Rectovaginal Health in She. Amazing people are going to come from all over India and abroad, and we are already there. We're looking forward to all of you being here.
Okay, so see you soon.
See you soon. Thank you.